Hello everyone, my name is Lucas Morin and I'm very honored and very proud to receive the CAPC Early Researcher Award 2020. It gives me a lot of pleasure to be giving this plenary lecture. I would have hoped to see you all in Palermo, but for obvious reasons that is not possible. So I'm gonna try my best to make it exciting also over this video conference. So the title of the presentation is Critical Issues in Drug Prescribing at the End of Life. And the main point that I'm trying to make is that we know underuse, not using healthcare services, not using treatments that we need is bad for your health outcomes, but overusing it is equally bad. So overuse is the provision of medical services that are more likely to cause harm than to do good. It's a very simple definition. And there is a lot of evidence nowadays around the world that the overuse of medical services, the overuse of diagnostic techniques and treatments actually leads to a substantial amount of harm and negative consequences. Overuse has two different compartments. The first one is overdiagnosis, looking for conditions and finding conditions that will never have caused harm during a patient's lifetime. And overdiagnosis is a pretty big deal these days, especially because of the new technique that we have at our disposal, the new test, and the fact that they have become much faster and much cheaper over time, makes that we are looking for and finding non-pathological conditions that would never have given rise to anything anyways in the first place. And one of the problems of overdiagnosis is that it can actually trigger what Deborah Korenstein described as a downward spiral of healthcare services use. So overdiagnosis typically gives rise to overtreatment, that is, medical interventions, treatments that provide a trivial or no benefit at all during a patient lifetime. And the presentation is going to focus on this issue of overtreatment, specifically on the overuse of drugs at the end of life. So you can think of four typical scenarios. The first one is the easiest and also nowadays the least common one. The treatment achieves a physiological target, but it provides no clinically relevant benefit. You can think here of atenolol, a beta blocker, that does reduce the systolic blood pressure in a very effective manner indeed. But when we looked in the early 2000s at the decrease in mortality or in the decrease of myocardial infarctions and strokes, we found basically nothing. So it does lower the blood pressure, but that physiological change does not translate into something that the patient actually values, which is the fact that it avoids negative health consequences. The second example is that of drugs that have a risk of harm that exceeds their potential benefit. So the drug works, but it comes with a fairly poor safety profile. So in old age, the typical example of these drugs is what we call inappropriate drugs that are, for example, pretty well tolerated by people like myself, who are young, fit, and relatively healthy without other drugs, without other chronic conditions. But when people go older and their kidneys start to dysfunction and the number of chronic diseases starts to pile up and the number of drugs also starts to accumulate, then the risk of harm of that medication can potentially outweigh the benefit. But that's not what I'm going to talk about today. What I'm going to talk about two scenarios that have to do with the patient more than with the drug. The third scenario is that of a drug whose goal is no longer aligned with the patient's priorities. So for example, the treatment is targeting an extension of life, and the patient would actually favor quality of life over the length of that life. And the fourth scenario is that of a drug that needs more time to accrue its benefit than the patient can afford. And we are going to focus on that. And the reasoning behind this sort of categorization in scenarios comes to Holly Holmes, who in 2006 and then 2008 described the reasoning behind what makes medications appropriate as people advanced through aging, serious illness, palliative care, and finally terminal care. And the key point is that as people go through these different steps, we need to increasingly individualize drug therapy. We need to think not only in terms of pharmacology, but also in terms of clinical paradigm and clinical trade-offs. And that is especially true because most older adults who reach the end of life have an exceptionally high burden of multimorbidity. So if you take the 10 most common chronic conditions in the last year of life, you can actually look at the prevalence rate of each of these conditions, but you can also look at, among people who have a certain chronic condition, how many other comorbidities do they have? And if you take the example of heart failure, you see that 39.3% of people at the end of life, of older adults, have heart failure in the last year of life. But you also see that 70% of these people with heart failure have, on top of heart failure, at least 6 or more chronic comorbidities. Now, with that in mind, you can actually split the problem in 3 dimensions: the goals of care of the patient, the time to benefit of the medication, and the risk of harm that comes with using the medication in the context of an old person with, most of the time, polypharmacy and multimorbidity at the end of life. And if you take these 3 dimensions, you can actually build up some kind of a narrowing pyramid like this, starting with, in old age, all the medications that have a favorable risk-benefit ratio. So that's mostly on pharmacological grounds. And as people get, for example, the serious disease, we are going to try to narrow it down to medications that will achieve their benefit before the patient dies, to medications that are perfectly aligned with the patient's stated preferences regarding the goals of care. So trying to get rid of medications that are simply not pursuing something that the patient wants. And during the final weeks, maybe months of life, one would try to focus medications and the medication burden around the alleviation of distressing symptoms and the management of comfort. The idea behind that is very simple, is that drugs that are usually appropriate, meaning pharmacologically appropriate, can become inadequate at the end of life. The question is no longer, is the drug safe and effective? The question becomes, will the drug achieve a benefit that the patient finds meaningful during the time that he or she has left? And we looked in my PhD thesis, in my work in the past few years at Karolinska Institute in Sweden, we looked at how that actually translates into practice. And the first question we had is, how does the burden of prescription drug evolves or develop throughout the last year of life of older people? And this is something we published in the American Journal of Medicine in 2017. You can go and check it up. It's open access. And we included every older person who died in 2007 to 2013, so an 8-year period. And we looked at data from 5 different national registries with individual record linkage covering the entire country. And we looked at polypharmacy, the use of several drugs at the same time. And we also looked at which ones were the most commonly used drugs. And because this is a registry-based study, we of course cover a massive population, in this case about 500,000 people. 2/3 of them were living in a community and about 1/3 in institution, in nursing homes. And to our surprise, as the end of life approaches, the number of drugs does not decline. It actually increases fairly steeply, about a 56% increase between the 12th and the final months before death. And this is not just an artifact that has to do with like a cutoff effect of plus or minus 10. No, when we look at the mean number of prescription drugs, we see the exact same pattern of increasing number of medications as death approaches. I would not go into details too much, but what we also found is that there were pretty important differences according to the illness trajectory of these people at the end of life. And that, of course, people who died suddenly had the lowest increase, or the slowest increase, in fact, in the number of prescription drugs, and that people with cancer had the fastest and most substantial increase, especially during the very final months of life. And we also found that although in nursing homes people were receiving more drugs, or many more drugs, 1 year before death, these number of drugs actually remained fairly stable, while in the community they started from a lower point but increased at a faster pace. And what we also found, and that was a little bit surprising to us is that about half of the top 15 drugs prescribed at the end of life had nothing to do with symptoms or comfort. They were actually drugs meant for the prevention of long-term chronic diseases. So for example, low-dose aspirin, beta blockers, ACE inhibitors, cardiac glycosides, statins, calcium channel inhibitors, drugs used for diabetes, especially glucose lowering drugs. So drugs that really are prescribed mostly for the prevention of recurring events or for the prolongation of life. But something that came up is maybe we were not looking at people who knew and whose prescriber knew were at the end of life. Maybe that is just a bit of a source of bias here, is that the number of drugs kept increasing because part of that population didn't know they were at the end of life. That's a fair point. So what we did is that in a second study, we focused on people who died with advanced cancer, with advanced solid cancers, and we looked at especially preventive medications at the end of life. And that was published in Cancer in 2015. And we included 151,000 people who died of solid cancer between 2007 and 2013. And we looked at drugs deemed preventative in nature based on a systematic review by our colleagues and friends, Adam Todd from Newcastle and Holly Holmes from Texas. And what we found is that even in that population of people who died from cancer, so a population for whom the end-of-life trajectory is especially easy or evident to spot at least a few months in advance, we found actually that antithrombotic agents remain extremely stable, that drugs used for the treatment of hypertension remain remarkably stable, and that even statins had only a modest decrease at the end of life. And you see that about 17% of older people who died from cancer received statins during their last months of life. Now, can these drugs really be considered as being of limited clinical benefit at the end of life? What makes us say that receiving statins or receiving antithrombotics or receiving antihypertensives is a bad thing? And indeed, because we are not including these people in randomized trials to check whether what we think we know about the benefit of these medications actually holds true at the end of life, well, we are a little bit on shaky grounds, and we don't really know which of these drugs can be prescribed and which ones should not be prescribed. So to separate the wheat from the chaff, what we did is that we asked in this publication from 2018 in the European Journal of Clinical Pharmacology, we developed a set of explicit criteria by consensus. So what we did is that we invited the Delphi panel with experts from 10 different European countries. It was online, so people did not meet in person. And based on the literature of the review of the literature and a first sort of tentative list of drug classes, we asked experts to grade drug classes and to categorize these different drugs in 2 different Delphi rounds. And we invited 58% of them, experts that we identified through learned societies and key publications, and then with a snowball effect. 40% of them agreed to participate with a fairly good European representation. And the question we asked them to separate the drugs is, in your opinion, among older or for older adults aged 75 and older who have an estimated life expectancy of 3 months or less, how adequate or inadequate are the following drug classes? And we asked them to think of 2 different scenarios, 2 different ways of approaching the problem. Is the continuation of a drug class adequate or inadequate? And is the initiation of that drug class adequate or inadequate? Because of course, not stopping a medication is not the same as starting that medication. And as often, I was going to say of course, but as often this was done with a Likert scale, going from always inadequate to always adequate. And once the first round was completed for drugs that did not reach consensus immediately, and it was most of them, we sent control feedback to the experts before they gave their second round. And this is exactly how it would look like. So the initiation of that drug would be already cleared from the first Delphi round. It's considered as often inadequate. But for the continuation, you can see that the opinions are quite widespread. So we asked the experts to regrade it, taking into consideration their suggestions, in this case, to consider anticholinesterase inhibitors and memantine separately. And then, as always with these types of studies, the experts would be asked to actually grade only the parts that did not reach consensus before. And so we built these two lists: drugs considered for continuation or initiation at the end of life, and they could be considered often adequate, questionable for use, or often inadequate for continuation or initiation at the end of life. And I will not go into details here because you can find that paper and these slides at your convenience. But what we found is that the list of drugs deemed inadequate for continuation was much shorter than the one for initiation. So experts deemed that starting some medications at the end of life it's easier to recognize that they are inadequate, and that all of these drugs have a common denominator. They are for either curative or preventive purposes. Interestingly, surprisingly but interestingly, no consensus could be reached for very commonly used medications at the end of life, including proton pump inhibitors, PPIs, furosemide, antibiotics, zopiclone and zolpidem, SSRIs and antidepressants in general, and haloperidol. And that is interesting because these medications are really widely used at the end of life. They have absolutely no robust evidence to support their use at the end of life, and they don't even have expert consensus to back up their utilization. So that raises a fairly thorny ethical question in my opinion. So once we had that list, the question was fairly obvious: is how many older people keep using drugs that experts think are inadequate at the end of life, and how many people initiate drugs that experts think are inadequate. And this was published also in 2019 in Palliative Medicine. You can find the paper because it's open access and easily accessible. What we found in a cohort of 58,415 people, aged 87, 56% of them women, 58% living in a community, and 36% dying in hospitals, is that about 1/3 continued at least one drug deemed often inadequate, and 14% initiated such a drug during their last 3 months of life. And without going too much into the table, because it's a little bit busy and messy here, but what we found is that the illness trajectory and the perceived or the estimated hospital frailty score mattered a lot for the continuation, but less so for the initiation of medications, and that there was absolutely no difference in the likelihood of continuing inadequate medications between nursing home residents and community dwellers. However, people in nursing homes were much less likely to start new medications of inadequate nature. The top 5 medications that are continued or initiated at the end of life are statins, calcium supplements, anti-dementia medications, drug for osteoporosis, and vitamin D. And the figures that you can see in the green column on the right are the percentages of people who were treated 1 year before dying and kept being treated until their last months of life. And in a graphical way, this is how it looks like. So this is the drug utilization pattern during the last 12 months of life for these 5 different drugs. And you see that except for statin, that actually sees a little bit of a tipping down in the very last months of life. For all the other preventive medications, there is absolutely no discontinuation. And although that is true during the last year of life, if we take a step back and look at the last 5 years of life, you actually see that statins are going down quite a bit, while the other ones not only remain stable during the last year of life, but they actually increase during the last 5 years of life. Now, most of these drugs, most of the drugs used at the end of life can be used, even if it's off-label, for symptom management or for the alleviation of distressing symptoms and to ensure comfort, no doubt. But most of them actually fit into one of these other 4 categories: controlling life-threatening comorbidities, the prescription cascade, prescribing cascade, so treating the symptom or the side effect of a different drug, thinking that it's a new symptom. The primary prevention of cardiovascular diseases is a huge driver, and slowing the progression of the main illness, although not the most common reason for the drug being continued is still fairly present. One reason for that is that we love medications, is that the prescribers love them, the patients love them, the relatives love them, and we have an impulse to treat every single new problem that arises with a new treatment, never to stop them. The second reason is that prescribers and patients alike are doomed by what David Cazaret nicknamed the therapeutic illusion. That is, the underestimation of things that are completely outside of our control and the overestimation of the control that we have over the disease trajectory and the course of the disease with treatments. We are constantly the victims of an illusion, which is that we can have a substantial, a clinically meaningful influence on the way things are going to evolve, and treatments are the tool through which we have that illusion, or we act on that illusion. And this is, if you haven't read it, a very, very nice, insightful piece in the New England Journal of Medicine. Another key driving factor is the fact that there is clearly a lack of communication around the deprescribing of treatments, of long-term treatments at the end of life. And that when there is communication, a lot of qualitative studies are showing that from the patient's point of view or the relative's point of view, there is a lot of miscommunication and misinterpretations, that people do not understand correctly why the question arises of maybe not continuing a certain medication. Finally, there is an objective issue, which is that guidelines often tell when to initiate therapy, but seldom how to deprescribe it. And that again comes from the lack of robust evidence to tell us and to sort of rationalize the benefits and the harms that one can expect from medications as they reach the end of life. But I would also like to point the fact that most of the work I've been presenting comes from retrospective cohorts of dissidents, so selecting people who died to reconstruct their healthcare utilization. And it's a little bit like Back to the Future, is that it leads to a lot of biases or a lot of misinterpretation, and then it can actually sort of lead us astray. And to put it in more academic terms, it is a study design that is not optimal to judge whether medications are beneficial or not at the end of life. This is a very harsh and strong critique from Peter Barr, published in the JAMA in 2004, saying that resurrecting treatment history of dead patients should be laid to rest. And in addition to that, I would also like to point out the fact that in the famous pyramid of evidence, we are roughly at that stage, which is that relying on Delphi consensuses and trying to see what experts think are adequate or inadequate drugs at the end of life is one of the lowest possible forms of medical evidence. And we need to be very honest and transparent about it. Now that I've presented these results, what are the next steps in terms of academic and scientific endeavors for the next few years? Well, I think one of the key priorities should be in measuring the harms of overprescribing. We need to demonstrate that the overutilization of medications not only is pointless, but potentially does a lot of harm. Because if it's only pointless, maybe we can move on to something that actually matters. And the main problem of measuring harms is that it requires an enormous amount of people and data, because these harms are most of the time, and hopefully so, and fortunately so, fairly rare, and randomized controlled trials are typically not powered to show and demonstrate these harms. So we need big data, we need observational data, and that comes with the big problem is that, of course, these data are not randomized, and drawing causal relationships between the prescription of a treatment and the associated harms is a very challenging task for many reasons. In addition to that, to looking at harms and investigating observational data, we definitely need to have pragmatic clinical trials assessing the efficacy and the safety of deprescribing strategies. It's not enough to use observational data. It's not enough to have anecdotal evidence. It's not enough to do qualitative studies to understand why deprescribing could work or could not work. We actually need to prove that it leads to substantially better outcomes among patients. That has been done already once by Jean Kuttner and her colleagues on statins, but this was a superiority study that failed to demonstrate superiority and sort of demonstrated non-inferiority, but in a way that is only half convincing. And I hope Jean is not listening to that slide and to that comment. But what I'm trying to say is that this is a landmark trial because it proved that we can do randomized control trials of very high quality in this field of deprescribing long-term medications at the end of life. But we need to do it for many more drugs, and we need to think of it either in terms of non-inferiority or in terms of superiority. And if we do that, we need to ask questions that matter so that we can provide answers that help. And the question that a randomized control trial would typically answer is, on average, does deprescribing of anything improves the well-being and quality of life of patients with advanced illness? And the key part of that sentence is on average. This is what randomized control trials are designed to find. It's an average effect, not an individual effect. And the question that I think would be more relevant is which patients at the end of life are the most likely to derive a meaningful benefit from deprescribing, because it is very possible that the average effect is very modest or non-existent, but still some patients, some high-risk patients, could derive a meaningful benefit from deprescribing, a benefit in terms of quality of life, that's obvious, but also a meaningful benefit in terms of avoiding harms and extending life because of a lowering of life-threatening adverse effects. And we also need to be wary when we ask these types of questions that we are not including the typical people that we include in randomized control trials all over the world, which is this person. We need to try to include this person in the middle, or even better, we need to find ways to have quasi-experimental studies or randomized control trials that are pragmatic enough to accommodate the inclusion of the people that we are actually trying to care for in the clinical setting, which is the person on the right of my screen. Thank you very much, and you're very welcome to contact me if you want to know more or if you want to get in touch. Thank you.